The human arm and hand perform incredible feats of mechanical precision, but executing those movements requires a massive, continuous supply of high-pressure blood. Delivering that energy is the responsibility of the brachial artery, the primary arterial conduit feeding the entire upper limb. Anatomically, this vessel is the continuation of the axillary artery, changing its name as it enters the arm. From this point, the artery supplies the muscles of the arm, the complex elbow joint, and the entire forearm. A textbook list provides the necessary vocabulary, but clinical application requires us to convert those terms into a functional, three-dimensional spatial map. Establishing this map is the direct foundation for vital procedures like blood pressure monitoring and emergency hemorrhage control. Understanding this specific anatomy provides the blueprint required to navigate and salvage the upper limb. Let's build that spatial map using the skeletal structure of the humerus as our base landmark. To find the exact origin point of our artery, we first locate the lower border of the teres major muscle. The moment the main arterial line crosses this specific muscular boundary, it becomes the brachial artery. Initially, the vessel tracks downward and laterally, running along the upper part of the arm. Halfway down, it makes a topographic shift. The artery alters its course to pass medially in the lower half of the arm. It settles directly into the medial bicipital groove, a recess that guides and protects its descent. Following this groove, the artery arrives at the elbow joint, dropping into the shallow depression of the cubital fossa. We can pinpoint its exact termination point on the skeleton. The artery ends opposite the neck of the radius. At this marker, the main trunk ends by dividing into two distinct branches, the radial and ulnar arteries. This lateral to medial shift keeps the artery relatively superficial. That positioning allows it to remain palpable and clinically accessible along the length of the arm. The longitudinal path of the artery is only one dimension of the map. We must also account for the depth and the layers of tissue that surround it. Looking at a transverse cross-section of the mid-arm, we see the artery is shielded anteriorly by the skin and the superficial fascia. Beneath those superficial layers lie the deeper boundaries, the deep fascia and the biceps brachii muscle. Posteriorly, the artery rests firmly against the triceps muscle. The lateral borders are framed by the coracobrachialis and the biceps brachii, leaving the medial aspect of the vessel relatively exposed. Muscle and fascia are not the only structures in this compartment. The median nerve shares this space, creating a critical neurovascular relationship. This relationship is highly dynamic. As the nerve and artery descend the arm together, their spatial positioning shifts. The median nerve begins on the lateral side of the artery, then distinctly crosses from lateral to medial as it moves down the arm. Because the artery is armored posteriorly and laterally, its exposed medial aspect and this crossing nerve dictate the precise angle of surgical approach. All of these structures converge at the elbow in the cubital fossa, the most clinically dense anatomical intersection in the upper limb. Navigating this space safely relies on identifying a sequence of structures from medial to lateral. The most medial structure is the median nerve. Moving laterally, you find the brachial artery, the biceps tendon, and finally the radial nerve. While this sequence governs the elbow, we must also identify the artery's branching hierarchy. Looking at this flowchart, the profunda brachii artery acts as the deep supply line, the primary branch in the arm. Below that are the nutrient artery to the humerus, muscular branches, and the superior and inferior ulnar collateral arteries. Knowing this exact medial to lateral arrangement and the branching tree is what separates a successful venipuncture from an accidental nerve injury or arterial puncture. All of this spatial data informs bedside practice, where we apply these anatomical relations to clinical mechanics. This data is the basis for routine blood pressure measurement. Because the artery takes a medial course, it sits close enough to the surface to be compressed by a standard cuff, allowing for non-invasive hemodynamic monitoring. Arterial cannulation relies on this same logic, requiring the clinician to avoid the median nerve and navigate the bicipital aponeurosis. In trauma scenarios, this map is used for severe hemorrhage control. Stopping an upper limb bleed relies on the artery's proximity to the bone. Applying direct external compression to the medial side of the arm leverages the humerus as a backstop to flatten and occlude the vessel. However, total arterial occlusion, whether from injury or prolonged compression, has serious consequences. If the primary conduit is blocked, ischemia begins in the forearm and hand, leading to rapid downstream physiological failure. The topography of the brachial artery is a map clinicians use every day.